Thank you everyone for taking the time to join us for what is our 7th Lunch and Learn session of the year. I'm Nikki Kinloch, I'm the CEO of Cure Cancer, and it's a pleasure to have not one but 2 people with us today. We have Dr Eric Kusnadi, who we funded in 2023, and Dr Louise Kostos, who are both based at the Peter MacCallum Cancer Centre at the University of Melbourne. We're incredibly excited to be able to offer you 2 perspectives of different experts in the field of advanced prostate cancer treatment today. And with the end of the financial year approaching, we would greatly appreciate it if you may consider making a tax-deductible donation to male reproductive cancers like prostate cancer. You can use the QR code that you can see on screen or the link in the chat as well. So on to the discussion today. Feel free at any point to drop comments into the chat box. You can see a little chat icon at the bottom there, and I will weave those questions into the chat as I talk to both Dr. Eric and Louise as well. So who have we got here? Dr. Eric is a postdoctoral researcher, while Dr. Louise is a medical oncologist. Although they don't work on the same project, they're both focused on prostate cancer, specifically metastatic castration-resistant prostate cancer. Each year in Australia, sadly, there are over 24,000 diagnoses of prostate cancer and around 3,500 deaths. Standard treatments include surgery, radiation, and testosterone-deprived therapies. Unfortunately, though, many patients still develop advanced cancers that then spread around the body. Dr. Eric and his team have developed a new drug that they hope will combat this frequently lethal disease. This drug interferes with a mechanism that is excessively used by prostate cancer and has shown some very promising results in preclinical trials. So to learn more about the wonderful work both Louise and Eric are doing, I'd like to welcome you both. Welcome to the session today. So,
thanks so much.
Eric, why don't we just start with you? What kind of brought you into cancer research before you got involved in prostate cancer and the great work you're doing now? Can you just talk a bit about your background and why you were interested in cancer research?
First of all, thanks for having me and for introduction, and hello again to those tuning in today. So what brought me to prostate cancer? So my background is biochemistry, and the key biochemical process that I was studying during my PhD is called mRNA translation. And it was discovered that this mRNA translation mechanism is often abnormal in prostate cancer cells. So even though I was studying blood cancer during my PhD, I'm able to translate what I learned about this mechanism to prostate cancer. And now I'm privileged that I have the opportunity to contribute my expertise in biochemistry to help develop new treatments that target mRNA translation in prostate cancer.
Lovely, thank you. And Louise, the same question for yourself. What brought you into cancer research?
Yeah, so for me, it happened quite organically. I guess I've always been exposed to a lot of prostate cancer with my medical oncology training. So over the years, I sort of became more comfortable and I guess was naturally drawn to genitourinary cancers, particularly prostate, because I felt more confident managing these patients. And then I did a fellowship in the early drug development team at Peter Mac and became particularly interested in early drug development and early trial design. And then it was really just the opportunity presented itself to start a PhD in prostate cancer, sort of merging those 2 worlds. So early drug development and trials with prostate cancer. And I guess also prostate cancer, it's evolving so rapidly at the moment with so many novel therapies. It's so interesting as a clinician to see how things have changed and the different opportunities for patients. So for me, it was more that it's interesting from a science perspective, but also I'm able to sort of utilize my skills in early drug development as well. It sort of led me to do my PhD.
Lovely, thank you. And whilst Eric's a researcher, you're a medical oncologist. And for those that aren't aware of what that is, could you just explain the difference between what Eric does and what you do?
Yeah, sure. So I completed medical school. So I did an undergraduate degree in medicine and then did specialized training to be a physician and then an extra 3 years in medical oncology. So I completed that in Melbourne 4 years ago. And then since then, I've been working primarily as a medical oncologist. So typically as a medical you can sort of make it what you want. But for me, it's typically outpatient based. So seeing patients in clinics. For me, most of my patients have prostate cancer and the clinics are about seeing patients really from the start of their diagnosis all the way through to end of life care. And I see patients on treatment, manage treatment toxicities. I see a lot of trial patients. And the other thing with cancer that I really like is it's very collaborative. So there are a lot of multidisciplinary meetings you attend as well as an oncologist, where there's surgeons there and a radiation oncologist, radiologists, etc., to really get the best treatment plan for each patient. And then also as a public hospital, Peter Mac has an emphasis on teaching as well. So there's always informal and formal teaching of the more junior staff involved in sort of everyday life as an oncologist. And then there's the laboratory side, which I'm just getting used to.
It's very different, but it's a privilege to have you both here today, because working closely together, researchers and oncologists, you know, being in touch with the patients and then taking that back into the lab and improving either treatments or diagnosis is really important. So thank you both for being here today. Eric, I said in my introduction about prostate cancer that sadly it goes on to people who had prostate cancer go on to develop other cancers that spread around the body. We'll talk about the drug you've developed in a moment, but why does that often happen?
Sorry, would you be able to clarify why would advanced prostate cancer often
Why
happen?
does it not often spread around the rest of the body?
Or why does it often? So for prostate cancer, at the early stage, it is usually quite well managed, for example, by surgery or radiation therapy. But in the majority of patients, the cancer can come back at the later stage of their life. And usually this cancer have adapted to the initial treatment and they spread around the body. Okay.
So we talked about you developing a drug that interferes with a mechanism that is used by prostate cancer. Could you talk us through how you developed that drug and what it does?
Yeah, so this drug is a second generation version of the compound that target that specific mechanism. With the first generation, it was originally developed for, again, blood cancer, but we found that it's also efficacious in solid tumor. So of course it started with, you know, treating cells that were grown in culture in the lab, and then we tested preclinically, and then with the drug that thanks to the support from Cure Cancer, we were able to complete the phase 1 trial of this compound. And not only completing the trial, we were also able to do additional biomarker analysis, and that will help us to continue to phase 2. So it has taken 8 to 10 years to develop this drug, starting from the first generation. Then we adjust the chemistry a little bit to generate the second generation, and then a lot of testing in the lab until we can finally complete the phase 1 trial.
It's interesting. We talk about this quite often when I'm interviewing researchers, that treatments or drugs can be invented or developed to treat one type of cancer and then go on to actually work on other types of cancer too. So the fact that this worked with blood cancer and then to solid tumors as well is really exciting.
Yes, definitely. Yeah.
So when you started to develop version 2 of this drug, what are the mechanisms? What is it doing to interrupt the cancer?
a lot of my research is about studying the molecular reasons as to why cancer cells can outgrow normal cells. And the key mechanism is that they kind of hijack this mRNA translation mechanism that I briefly mentioned at the start. So this drug, and in cancer cells, they hijack this process and they're kind of addicted to this process. So when we add this compound, which inhibits, which target that process, the cancer cell just stop growing, but a lot of them died, whereas the normal cells are unaffected because they are not addicted to this process. So that's why it's a really interesting development, because we were able to develop something that is efficacious but quite safe as well.
Fascinating. So it only targets the cancer cells because they're addicted to that mRNA process.
Yes.
But the non-cancerous cells are safe, so it's not actually destroying those at the same time.
Yep.
That's incredible. So we've talked about preclinical trials. What do you need to do then to move forward? Obviously, you've had some really positive results in preclinical trials. What do you need to do to move forward to be able to take this to a clinical trial?
Yeah, so this drug actually has completed the preclinical trial 3 years ago, and it's actually now in it's actually completed phase 1 as well, as I mentioned, thanks to Cure Cancer support. And now we are looking for funding to start our phase 2 trial. So in phase 1 trial, the purpose of phase 1 trial is to test the safety and the maximum tolerated dose of this compound. And we now know the recommended phase 2 dose. We have established that the compound we can proceed to the next phase. And yeah, so now we are about to commence the phase 2 trial of this compound.
Great. And how long does a phase 2 trial normally take?
So it can take anywhere between 2 to 5 years. It again depends on funding. If we look at the development of COVID vaccine, because there's so much money being put in the program, and different groups around the world are trying to solve the same question. You know, a vaccine can be approved by the FDA really quite rapidly, whereas for this kind of trial, obviously we have to recruit patients, and then we have to monitor them, see to confirm whether the drug is actually working. It's reassess the safety and efficacies parameters to ensure that it can go again, move forward to phase 3 and phase 4, and towards the approval by the regulatory bodies.
That would be wonderful, absolutely. So just to be clear, obviously Eric's looking for some funding for that phase 2. So if anyone is interested in exploring that more, please drop us a line at info@curecancer.com.au and we can connect you with Eric. Louise, can you explain why this sort of advancement in the treatment of prostate cancer is so important for patients that you were dealing with?
Yeah, so I think, I guess, generally speaking, when we think of prostate cancer, particularly towards the end, so metastatic castration-resistant prostate cancer, it's still incurable. And even though there's been quite a lot of progress in treatments in recent years, the prognosis is still quite short. It's on average about 18 months. And even with that survival, often patients have a high burden of symptoms during that time as well. So we still have a long way to go in terms of optimizing the treatments available and trying to find treatments that will provide more durable benefit. But one of the other, I guess, aspects of prostate cancer is we're seeing a real paradigm shift where we are trying to intensify treatment through combinations and give it earlier. So potentially patients are receiving more toxic treatments for hopefully better survival. But for some of those patients, it doesn't work for them, and then they've got extra toxicity. So developing personalized and targeted treatments, like what Eric's doing, I think is really important, because then we can know, I guess, optimize patient selection for treatments a little bit better and try and spare those patients who probably won't respond from toxicity, and avoid over-treating some patients.
Yeah, we talk about that a lot, don't we? Because in the past, it was almost like a one form of treatment fits everyone. But in fact, now that we have the ability to look at tumours in so many different levels, that we can actually now provide this more personalised treatment too. And we've also talked about before, and you probably see it firsthand, that the treatments are incredibly brutal, and some people can die from the treatment, not from the cancer as well. So a better form of treatment that's more relevant to that tumour is really important. Is that right?
Yeah, definitely. I think rather than following an algorithm of which is sort of a sequence of treatments that everyone gets the same, I think ideally we would be able to develop some biomarkers and know which patients will respond or won't respond to certain treatments, and sort of tailor each patient's treatment individually so that they're receiving the most effective treatment first. And the other thing with prostate cancer, and it's probably similar across other cancers as well, is that you always have to give the most effective treatment first, because we know that not everyone's going to be well enough to receive another treatment after. And unfortunately, if a patient gets a treatment that they're probably not going to respond to, they're not always going to be well enough to get the next best treatment after that.
Yeah, of course, that's a very important consideration.
Yeah,
So pause there and welcome our new guest. Thank you for joining us today. We are very fortunate to have our researcher from 2023, Dr Eric Kusnadi, and medical oncologist Dr Louise Kostos here from Peter Mac in Melbourne, talking through advanced prostate cancer for us. Just in your conversation a bit earlier, Louise, you were talking about castration-resistant. Could you explain a bit about what that means and why the research that Eric is doing is so important for that type of cancer?
Yeah, sure. So I guess prostate cancer in general is generally driven by testosterone. So the mainstay, or sort of the backbone of treatment, is inhibiting testosterone, or what we call androgen deprivation therapy, or ADT. So prior to 10 years ago, that was the only treatment we had for prostate cancer in the early stages that had spread or metastasized. So when patients no longer respond to that treatment, so if they're on ADT and their testosterone levels in the blood are really low, but the cancer is progressing, that indicates to us that they're now castration resistant. So basically they've got castrated levels of testosterone, but the cancer is progressing. And unfortunately, this is a almost completely different phenotype to castrate sensitive or hormone sensitive prostate cancer. It's more aggressive. When we look at the genomic profile of patients, it's quite different to patients in the hormone sensitive setting, and their prognosis is poorer. So I think that's why there's also been a shift towards treating patients earlier in the hormone sensitive setting to sort of delay the onset of castration resistant, or, ideally prevent it.
Yeah, okay, thank you for explaining that. That makes sense. Just a reminder for everyone that's online listening to us, if you do have any questions, either for Eric or Louise, please drop those into the conversation box as well. So Eric, back in the lab, can you explain what if there's such a thing, a typical day for you looks like in the lab?
Well, the typical day in the lab can kind of vary according to the season. What I mean by that is that in a year, there are experiment heavy seasons and grant writing seasons. So for example, during experiment season, usually in the morning, we check on the prostate cancer cells that grow in our incubators. And it kind of feels like looking after a baby, because you need to see whether the cells need more food or need their nappy changed, which means that, that we have to transfer the cells into a new vessel with fresh culture media. Then perhaps in the afternoon, we would add some test compounds to the culture and see how it affects the cell on the next day. And in the remaining times between these key experiments, I do peer review work, supervise students, train other staff members, and of course, lots of meetings.
Yeah, absolutely. I have a question here about the cells then. So if you know, but where do the cells come from that you you use in your research?
The cells, or it's the cells have it's called a cell line. So it was originated 20, 30 years ago from an actual prostate cancer patient. So there is a lot of development in the prostate cancer field to, rather than using these old, even though they are really robust and well validated, but the disease several decades ago and now can be quite different. So we also have cells directly from the patient. So at Peter Mac, there are a lot of tissue and sample collection programs. So it's a really great example of, as we always often hear, clinic to bench to bedside and bedside to bench translation. So we get the samples from the patient, and then we can try and grow them in the lab, and then we can test some compounds on them, and then that can inform whether the patients are eligible or are sensitive or for that kind of treatment.
Yeah, absolutely. And Louise, that's something patients or people that have been through treatment are often asked about, whether they will allow their cells to be used for medical research. And how important is that from your perspective?
It's really important, especially with my PhD. I have designed and now implemented clinical trials. So I can see patients, signing the consent that I wrote, and on that consent there's tick boxes whether or not they're happy to basically release their blood samples for use for future research or participate in optional biopsies. And I know exactly what the significance of that is, because I'm then going to analyze them. So majority of the time patients will say yes, and it really brings them a sense of fulfillment to be able to contribute to research as well. And I explained to them that we try and look at the samples, as promptly as possible. And if we do find anything significant, we'll feed it back to the patient and their families. If, for example, we find a germline mutation or a hereditary mutation. But most of the time, they're very, very happy to participate.
Yeah, that's wonderful. Thank you. And the same question to you. What does your typical day look like?
Yeah, so it's mainly outpatient based, as I mentioned before. So attending clinics and seeing patients who are on treatment or who have just been diagnosed and devising treatment plans for them, and also attending multidisciplinary meetings with various specialties. And then in between the meetings and the clinics, there's a lot of chasing investigations and, following up with patients or referrers. But that's sort of what a typical day would be.
Yeah, lovely. Thank you.
Thanks.
I have a question here about patient advocates and whether they're important or not. So Louise, why don't we start with you, and we'll ask the same question of Eric as well.
Patient advocates?
Yes.
Yeah, I think they're so important. And actually, there's a group in Australia called ANZUP who are involved with some investigator-initiated trials, and they actually have a patient advocate in their sort of protocol development team, because it's so important to hear the patient perspective. And I think it's very different in terms of what maybe the ethics committee or the legal team will tell us to write in a consent document, for example, to what a patient actually thinks is important to know and is easy for them to read. So I think it's really important to have the patient perspective, because often that's lost in with all the other teams that are involved. They're not sort of in touch with that side.
Yeah, absolutely. And Eric, what about you? How important is it to although you don't have first-hand relationship, but have that advocates that come and you can talk to in regards to your research?
No, I've actually been working closely with 2 consumer advocates in the past 3 to 4 years, and I'm really fortunate that both of my advocates are really experienced. They have been overseeing multiple research projects and working with more than 5 different researchers. So I'm more of a basic, molecular fundamental scientist. So the feedback from consumers based on their treatment journey is definitely important for me to understand the big picture. Yeah. And because of their experience, they have been helping me with my presentations by listening to my dry runs to make sure that the content is easy to understand, especially when I'm presenting to the public. They have also invited me to present in their support group meetings, which is great because it means more chance for me to learn from and engage more consumers. And my consumer advocates who are helping me for my project have also helped me to design projects, design new projects, prepare funding applications, and identify potential issues, for example, by ensuring that, you know, the experiments have the right control. So yeah, definitely consumer advocates, especially those who are involved in research, are very important.
Yeah, absolutely. Lovely. Thank you. So a question here about the challenges you face, because we all have challenges. Eric, what would you say are some of the biggest challenges you've had to overcome?
Yeah, one of the key difficulties in my research is that molecular science takes time. Again, as an example, my cure cancer project on the clinical trial of this new drug is actually the culmination of about 8 to 10 years of work by our team, including my PhD studies. So how do I tackle this? I guess I find that self-motivation can be quite important because, you know, we need to preserve the scientific drive and curiosity. And also, you know, there's always time and funding constraints. So yeah, these are some of the challenges.
It's remarkable to think, and I'm sure you've got hurdles or achievements you're doing every day, but to be working on one project for 8 years is an incredibly long time, isn't it? So you must have so much self-drive and motivation as well.
Well, yeah, and not only one project. Usually researchers like me have, you know, 3 or 4 concurrent projects. So yeah, we have to always try to be efficient in our management. Yeah,
lovely. Thank you. And the same question for you, Louise. What are some of the biggest challenges that you face?
Yeah, I think probably the 2 big ones for me. The first is time, more so as a clinician, just finding protected time to do research, because the clinical matters will always take priority. You always have to deal with patient matters first, so it is sometimes hard to carve away some time to write or to spend prolonged time in the lab. So that's sort of an ongoing challenge for me. But the other main challenge I faced was at the start of my PhD, trying to get the 2 trials that I'm running basically started. So most clinical trials are funded by pharmaceutical companies, and they sort of do everything and then give a hospital like Peter MacCallum a protocol and you're ready to go. But investigator-initiated trials, you sort of do everything yourself, and there's not really a manual to follow. So a lot of the time it felt like I was taking 2 steps forward, 1 step back, going through the different steps. If I ever did it again, learnt a lot in the process, but sort of navigating that blindly was probably the biggest challenge.
And also, how do you deal with the pressure of dealing with patients, patients that may not have the best prognosis, or, having to have that soft kind of personality to talk to them about some of the most difficult conversations you may ever have, but also making sure that you're doing it in a way that's appropriate and forward thinking from a research perspective as well?
Yeah, I think it's always a challenge. My approach is to try and be as upfront as possible and as soon as possible, so that you're not sort of surprising patients right at the end when they're deteriorating and it's all come as a surprise to their families. So I try and always discuss prognosis at the beginning, and I guess it's a little bit easier in prostate cancer because I can say, there is hope, there are lots of new treatments, we hope for the best, but this is the worst case scenario, so that they're always prepared. And yeah, just I think consistency as well, making sure you've got a relationship with the patient and their family definitely helps.
Yeah, lovely. Thank you. We've got a question here about whether there are any benefits of analysing benign and or rare samples or tumours. Eric, why don't we start with you there?
Yeah, it's always important to analyze the benign samples because usually benign is called prostate intraepithelial neoplasia. Is that right, Louise? PIN?
Yes. Yeah.
Yeah. Usually the pathways that eventually drive them to metastasize or grow into like a real aggressive tumor has already been abnormal at the PIN stage. So yeah, definitely. And the rare cancer is also important because in prostate cancer and in many types of cancer, there is a lot of heterogeneity, differences between samples isolated from different patients. And that's why there are many subtypes of prostate cancer. There's neuroendocrine prostate cancer, for example, which is still very little with survival of 4 to 6 months, and it's still incurable. So we definitely need to analyze all these rare cancer and the benign cancer.
Yeah, thank
Yeah,
you.
it's just add to that, it's really tricky with patients with rarer subtypes of prostate cancer because often clinical trials require that they have to have adenocarcinoma. And so when you see a patient with a different histological subtype, we can't sort of back it up with evidence and know exactly what treatment a patient should have because they're excluded from the big trials. So it's really, really important that they do get analysed in the lab.
Yeah, lovely. Thank you. Eric, you touched on funding being a challenge. Obviously, we funded you in 23 as an early career cancer researcher. Why is it so important to receive funding, like funding that we provide at Cure Cancer?
Funding like the one from Cure Cancer always means a lot to the person who, like for me, it's important for me personally and also to the research because for the scientist itself, like me, it always it can leverage the success of other funding scheme. For example, I recently received a Future Leaders Award from the Prostate Cancer Foundation of Australia. So it's really good for the career of the scientist and also for their research. We can for example, in my case, we were able to complete phase 1 trial, and then now we are going towards phase 2 trial. So all this funding and supporting early career researcher also takes us closer to bringing a new drug that can, to the clinic to provide hope and also help to improve outcomes for patients with advanced prostate cancer.
Yeah, lovely. Thank you.
Types of cancer, yeah.
So just want to talk about exciting developments. Eric, obviously you're hopefully going to a phase 2 clinical trial, which is an exciting development in itself. But what have you seen over the last couple of years with all your work on prostate cancer, and what's new and exciting that you can see happening?
Theranostics is definitely one of the most exciting development. Perhaps Louise can talk more about this as well, because that's Louise's PhD project. And so yeah, Louise and I are working on separate projects on theranostics as well. So theranostic means therapy and diagnostics using injected radiation to first detect advanced prostate cancer that has spread around the body. And then after we know where the cancers are around the body, a similar molecule is then used to deliver different radioactive payload and specifically kill cancer cells around the body. So I think, so essentially clinicians can kind of see what they treat. And this is a very good example of personalized precision medicine, because you first check whether the patient has the right biochemistry. And then if they are 100%, they are eligible, then they will be enrolled in this kind of treatment or trial. And we see a lot of great success from this theranostics approach.
That's incredible. So it goes around the body to highlight the other cancerous
Yes.
cell.
So yeah, it's delivered intravenously,
Yep.
and then the radiation travel, and it only binds to the prostate cancer while sparing all the normal cells around the body. It can seek and destroy, essentially.
Wow. And Louise, was there anything you wanted to add about exciting developments that you've seen?
I think I agree with Eric. I think the discovery of PSMA and then the development of PSMA theranostics has definitely been a game changer in prostate cancer recently. And I think now it's becoming standard of care that patients will be assessed with a PSMA PET scan, which is the imaging side of it. And then if they're suitable, get the targeted PSMA radiotherapy, which is what we call lutetium PSMA. But now it's moving towards trying to optimize that. So looking at better radioisotopes or better ligands to try and improve the delivery of the radiation and make it more effective, possibly with less side effects as well. I think that would be the first thing. And then the other thing for me is the emergence of circulating tumour DNA and its role in prostate cancer. It really, I think just in the last 12 months, it's sort of taken off, and we now know that the fraction, which is, I guess, the amount of the tumour DNA that's detectable in the blood, seems to correlate with outcomes. So it's prognostic, and also being able to analyse the genomic profile at baseline and then on treatments, we can identify markers of resistance or markers that might predict response. So I think, yeah, those two aspects are really, really exciting.
Yeah, lovely. Thank you. A question here about timeframes as well. You know, we always say that early detection is the most important. If someone has had prostate cancer detected later, do we see a severe drop-off in survival rate, or with the current treatment that we have now, that manages to hold true, that patients still have a good survival rate even if it's a couple of years later and the cancer's had a bit of time to take a hold?
No, it does matter. If patients are diagnosed with like metastatic or cancer that's already spread from the beginning, which is what we call de novo metastatic disease, unfortunately, they do have a shorter survival. So that's a poor prognostic sign in that case. And often that's because those cancers have actually grown faster, so they didn't have a chance to be detected earlier anyway. So if patients can be detected earlier, they also have a greater chance of receiving curative treatment rather than, I guess, in the metastatic setting where it's really just about disease control rather than cure.
Yeah, lovely. Thank you. One other question we've just got here about, is prostate cancer a degenerative cancer? So i.e., as you get older, are you more likely to have prostate cancer?
Yeah, it's certainly more common as you get older. Certainly age is a risk factor. With the younger patients, often they're the ones with an underlying genetic predisposition. So for example, their tumour might harbour a BRCA gene or another gene that predisposes them to developing prostate cancer. But most of our patients are sort of 70 plus years.
Yeah, absolutely. And Eric, for you as well, do you see a difference in cellular structures or the research you're doing based on the age of the sample?
Not really. Usually the difference is more driven by the aggressiveness of the disease. So it's not really about the age, but yeah, about the age, I can't remember exactly the statistic, but I think it's like 1 in 2 men for above 70 or something like that, right? Based on statistics, right, Louise? Or 1 in 3. It is really common for older age patient, I think.
Yeah, I'm not sure exactly how common it is above 70, but I think it's the second leading cause of cancer death in males.
Yeah, lovely. All right, we've just got 5 minutes left with Dr. Eric and Dr. Louise from Peter Mac in Melbourne. If you do have any other questions, please drop them into the chat and I'll ask them. So, question about reward. Obviously, both of you are doing highly stressful jobs, but what do you find most rewarding? Why don't we start with you, Louise?
Yeah, I mean, for me, one of the reasons I went into oncology is I find it really rewarding having that long-term relationship with patients. And even when my patients die from their cancer, it can still be really rewarding just to, be their support and offer, make sure they have a good death with their family. but also specifically to what I'm doing now with my PhD, it's so rewarding to be able to have designed a trial and then put patients on that trial and then see them doing well and responding. That's just the best. And now being able to sort of go into the lab and analyze their DNA further and see how that can help them. That's extremely fulfilling.
Yeah, absolutely. Thank you. And Eric, what's your most rewarding aspect of your role?
I guess it's intellectual satisfaction, because you always have to have scientific curiosity, and it's always exciting to be the first in the world to see some to get the exciting results, because we always have to research something that's novel, and I guess it's also quite rewarding to think that our research can eventually impact human health. So it's always rewarding to think that our research can make a difference to the overall health of the society.
Yeah, absolutely. And thanks to those donors that we do have on our call today, that your funding has helped Eric get to phase 2 of this trial, which is incredibly exciting. Before we wrap up, any last words that either of you would like to share with our audience today?
Do you want to go first, Eric?
Well, I guess maybe about the hope for the future of prostate cancer research. I guess our hope is that researchers around the world can continue our, collaborative efforts to keep improving the diagnosis of prostate cancer, treatment, and also patient outcomes. For example, we need, as there was a question about age, we need better biomarkers that can detect prostate cancer earlier. We need more molecular studies to find new targeted therapy as opposed to chemotherapy or hormone therapy that are more non-specific and cause lots of side effects. And we need more insights into immunotherapy or theranostics for prostate cancer. And also we need more attention towards the management of the quality of life and patient experience during and after treatment. So I guess, but fortunately, the hope for the future of prostate cancer research is quite bright, because there are ongoing studies around the world to address these issues. For example, Louise is working on circulating tumor DNA to so that hopefully we can find better biomarkers that can detect prostate cancer earlier. So yeah, there are a lot of research around the world to improve the diagnosis, treatment, and for prostate cancer, and also patient outcomes.
Thank you.
Yeah, I just wanted to add that I think we're so lucky at this point in time that prostate cancer has come so far and the research is moving so quickly. But I guess it's important to remember that the drugs don't just appear on, in the clinic one day. It's a long sort of 10+ year process that starts with scientists like Eric. So it's really, I guess, important that we can support research in any possible way to improve treatments. And I guess as we have come this far and continue to improve the treatments and survival, we're now sort of moving into a model where we really have to think about survivorship and long-term toxicity and balancing the risks and I guess the toxicity of treatments as well as the benefits of them. So it's a really interesting time at the moment to be involved with prostate cancer.
Yeah, lovely. Well, thank you both for joining us today. So Dr. Eric Kusnadi, postdoctoral researcher, and Dr. Louise Kostos, medical oncologist, both at Peter Mac. We appreciate your time and thank you for both of you for the incredible work you're doing. If anyone would like to find out more about the phase 2 trial that Eric is looking for funding for, we have info@curecancer.com.au in our chat box. It is also the end of financial year. Our focus is on men's cancers, reproductive cancers this year. So if you would like to make a tax-deductible donation, there is a link there in the chat as well. Thank you for joining us today. I hope you enjoyed this session. Please join us at the same time on the 11th of July for our Lunch and Learn with Dr. Kevin Fenix. He's at the University of Queensland, where he will discuss his investigation into a new type of immunotherapy for metastatic bowel cancer. So until then, stay safe, and we'll see you on the 11th of July. Thank you.